So, Steve, tell us about today's topic.
Well, this topic came up because a lot of people do not realize that there are more types of diabetes than just one or two. And you can throw in gestational, which usually occurs in women. And
That's your joke.
It's a joke. Come on. I know I can hear you
It's like
laughing.
a decades-long joke.
Decade-long joke. Well, someday you're going to use it. Yeah, and basically, type 1 diabetes can take many different forms. And the reason why it's extremely important, because many of you watching today may have one of those forms and you have been misdiagnosed. If you're misdiagnosed, you're not on the best therapy. But it's also good to be knowledgeable because you have friends that may have diabetes that's not responding normally to the typical medications they get, either type 1 or type 2. And LADA, which we'll talk about, LADA, many of you type 1s were misdiagnosed, but we're going to get into that. And the way we designed today's program is to go through the basic types and put in between and around the other types that might be related to type 1 or type 2. So we're going to go in an order that we think is the best, and we're going to cover a lot of stuff. So let's start, Jeremy.
Yeah. And the last caveat I'll say is that we're going to talk about these things in like these buckets. But a big theme is that there's a lot of overlap. You can have type 1 with features of type 2 and the other way around. So if you think, okay, like they're done with the type 1 part, that's me, and I'm going to tune out, please don't, because there is a lot that will pertain no matter where you think you actually fit.
And we want good ratings. So even if you go to the kitchen, leave your computer on.
Yeah. So I guess we'll just start with type 1, right?
Yeah. The basic type 1, and obviously that's the one that you probably know the most about if you have type 1. Then we're going to go to pre-type 1 and things like that.
So some of the like basics for type 1 diabetes, it is an autoimmune disease, which means that your body misrecognizes the insulin producing cells of your body as foreign. For some reason, it starts attacking, destroying them. And pretty soon after diagnosis, you need to go on insulin. So usually it's diagnosed in kids. It has these two little peaks in terms of onset around the age 4 or 5. When kids go to typically to school, we think there's something with that new infectious environment where kids get sick for the first time. And then sometimes around the age like 11, 12, that's where these little spikes in diagnosis. But we know now that more than half of the people diagnosed with type 1 diabetes are actually diagnosed as
adults.
So you can get type 1 at any age. So when you think type 1 is kids and type 2 is, adults, generally that holds, but not always.
Yeah, I recently diagnosed someone who's 78, and I've heard of older than that. But one thing I wanted to add to what Jeremy said, about when you're 4 years old, or your kid is 4 years old, and they get type 1. We don't know what causes type 1.
No, we don't.
It's not that substitute teacher that your kid went to. We just don't know. And that's one of the biggest things that we're looking for in research. We know more how to treat it than we do know how to prevent it. But we do have some advances, and we'll talk about that when we talk about pre-type 1.
Yeah. So in the areas of type 1 research, we talk about this a lot. We did our most listened to podcast is on the science of type 1 diabetes, where we talk about advances in research. But if the problem with type 1 is that we don't have enough beta cells, well, we're looking at stem cells to replace beta cells. Can we stop the immune attack in some way? Can we prevent it entirely? And prevention then really gets into this really brand new category of what we would call pre-type 1 diabetes, that you don't have type 1 yet, your blood sugars aren't high, but you have started to develop the autoimmune process.
Yep. And you mentioned the way you described type 1 was so simple, but great. Just like you get a scab, you fell on, let's say you fell down, and you have all this dirt, in your wound. What do your antibodies do? They recognize this dirt and whatever's in your wound as foreign, goes in there, attacks and kills anything that causes an infection, and then you heal over it. And we don't know why our own immune system attacked your pancreas and mine when we were both 15 years old and destroyed those very specific, what we call beta cells or islet cells in the pancreas. The pancreas has all kinds of cells, but for some reason it attacked those cells. Those cells secrete insulin. And pretty much every type 1 I know has been on insulin since they were diagnosed. And maybe there's a little honeymoon period after diagnosis, but it's pretty much you're on insulin the rest of your life.
Now, Steve and I were both diagnosed with type 1 when we were 15. We kind of had the classic peeing all the time, drinking all the time, went into DKA, just a few years apart, but otherwise very, very similar.
Yeah.
And now what we're going to talk about pre-type 1 is that even though Steve and I were diagnosed with when we were 15, that this autoimmune process had likely been going on for years, most likely for years, like when we were 10, 11, 12 is when the process started, but we were completely unaware of it because our blood sugars were normal. Well now, and actually it's not even that recent, we have these antibodies that you can test in somebody's blood to let you know if they're at risk for developing type 1. And they are highly predictive that as soon as you get 2 or more of these antibodies in your blood, you know that your lifetime risk of getting type 1 is 100%.
Yep.
You're going to get high blood sugars at some point. Your risk in the next 5 years is about 50%. So you're saying, well, okay, then who should we screen for these antibodies?
Yeah, and here's the thing. Right now, first-degree relatives of people with type 1 diabetes, our kids, our brothers, sisters, even parents, if you want to be complete about it, because you can get type 1 at any age. Also, recently, from great data that I presented
In Madrid.
in Madrid, that for people with celiac and hyper or hypothyroidism, many of those conditions that cause too much or too little thyroid levels are autoimmune based. And those folks have a much higher risk of getting type 1. But I think here's the big deal. If you talk to Jeremy and myself, who else in our family has type 1? No one. The vast majority of people who come down with type 1 do not have a family history. And that's why certain countries have already transitioned to screening the entire population.
Like Italy passed a bill and they're just trying to work on the logistics of how to do this. But at a certain age, I think they're working out around 5, they want to screen everybody.
They give the adults, the parents, wine while their kids are being screened. And that's how they attract in Italy.
So we're not there yet in the US, but like you might be hearing about this hopefully soon that we start rolling this out because we need to identify these people for a couple reasons. One, if we know who's going to go on to get, let's say, type 1 diabetes, you can start the education process. You can avoid DKA. You know, the reason we went into DKA is because we weren't on the lookout for that. We didn't know what diabetes was at all. I was drinking more water. I just thought it was like, hot out. And all of a sudden, guess what? DKA is a deadly situation. People still die from DKA. So if you know that you're at risk for type 1, yeah, it kind of sucks to have that information, but you're certainly going to catch it when your blood sugars become high and can really, it's been proven actually, help avoid DKA.
Yeah, and now they're screening people to be candidates for a therapy called TZIELD, which was approved by the FDA now 2 years ago. It's a 14-day infusion, only 30 minutes a day, and it somehow slows down the destruction of those beta cells. And in the clinical studies, they delayed type 1 on average by 3 years, some people longer, some people shorter. But those 3 years could mean a ton. If your kid is 5 years old, now you go to 8. And like Jeremy said, you can get educated as a family to be ready when it occurs. And also, if you screen and find out that you have those 2 antibodies and you decide you don't want to be in a clinical trial, at least you'll be educated and you'll be ready no matter if you join a clinical trial or not.
Yeah, and that's the great thing about this drug is it's not a clinical trial anymore. It's approved.
That's true.
So it's something you can get prescribed that you have these antibodies. It's an approved therapy, like Steve said, only 2 years ago. So to be honest, I've recently gotten my older child screened, and the reason that I was putting off like for so long was I kind of told myself, well, there's nothing to do about it. If the antibodies come back positive, that might stress me out that I have that information. There's no drugs available anyways. But now I think it's just something to push us more in the direction of, okay, there's an actionable item now. If I get my child or my brother or sister, like you said, your relatives that you actually like, to get them screened, there's something you can do about it.
Yeah, it's really important. And pre-type 1 was never talked about. It was always pre-type 2, which we're going to get to. But now we can do something about it.
Right.
And I should also mention that to get these autoantibodies tested, it could be a drop of blood on a card that you mail back in.
Yeah, so there's a website called type1tested.com, and they give you different options on how to do this. Or there's a research group called TrialNet, and you can go onto that website. They will literally send you a kit at home that you can do, finger pokes of, and you have to get quite a bit of blood, but you can do it with your finger. And again, my story was that I actually had these kits for a long time, tried to poke my son's finger, and he freaked out. So then eventually he had to get a blood draw for a different reason, and added those antibodies onto his routine blood draw, and that's how I finally got them back. And I will tell you, when those results come back, man, it's more intense than getting your SAT results or whatever. Like, you know, you're biting your fingers to see if these antibodies are positive now. So we get it, how like emotional this can be.
What was it?
They're all negative, thank you, or thankfully, knock on wood, yeah.
Yeah, I always kind of gave you a little bit of grief for not getting your kids tested, but it's a personal choice.
And again, this new drug, TZIELD, is approved for people 8 years and older. So it's another thing to keep in mind if you're on the fence about screening. So, all right, so we talked about the basics of type 1, you probably know. This whole new concept of pre-type 1 diabetes, that there's this whole period of silent type 1 that now we can screen for with these antibodies. But let's talk about LADA, because this might be the thing we get more questions about than like anything, potentially anything. And let's start with what does LADA mean?
Yeah, well, what does it stand for?
Yeah.
Latent, later in life, autoimmune diabetes in adults. And the way I describe it to people, it's type 1 diabetes that occurs later in life. But it's important to know that it comes on a little slower than when Jeremy and I got type 1, where we got thirsty, urinating, lost weight, crashed and burned, got diabetic ketoacidosis. And these folks with LADA, they just have high blood sugars. They don't go into DKA, at least not for many years. And because they're older, you got some goofball physicians who played basketball on the day they covered that in medical school or during their residency, and they just think they have type 2 because of their age. But they're thinner than a type 2. They don't have the, that's the physical stigmata, but they don't have the typical dyslipidemia, the high triglyceride levels we see in type 2. They don't typically have the high blood pressure, and they don't have a family history. People with type 2, 80 to 90% will tell you, yeah, type 2 runs strongly in my family from generation to generation, and it's commonly misdiagnosed.
Yeah. And honestly, the term LADA, there's some movement to just get rid of it. It just means you have type 1 diabetes that you got later in life. And people get really hung up on that term. Do I have type 1? Do I have LADA as my type 1.5? It's just type 1 later in life. And it's actually better to get it later in life because you can hold on to insulin production longer. So Steve just mentioned what this diagnosis can look like. So we had our good friend Aaron Kowalski, who's the CEO of formerly JDRF, now Breakthrough T1D, that was here just a couple weeks ago. And we had fun filming a little clip of what this diagnosis can sometimes look like in a bad way. So roll that clip here.
Hello, Mr. Kowalski, how are you?
Well, I just got my blood work back, doctor, and my blood sugar is over 200. I'm super nervous.
Classic case of type 2 diabetes. I'm going to send a script of metformin to your pharmacy, and you need to meet with the educator to start talking about exercising a little bit and maybe eating a little better.
But I already run every day, and
we all do our best, but we could probably do a little bit better. So why don't you tighten it up, Kowalski, and I'll see you in 6 months. Thanks.
All right, so if you're listening and you got diagnosed with type 1 as an adult, there's a good chance your, story went something like that. Your blood sugars were a little elevated, your doctor just said type 2, and sometimes it can take people years to get the right diagnosis, and they can be really frustrated by it. But once you get that diagnosis, you have type 1. Welcome to the family. There's nothing special or different about like your disease other than it attacks a little bit slower.
Yeah, we should mention that there's a simple blood test. Guess what? It's those insulin autoantibodies, and the one that we order the most if you're older and past the diagnosis of diabetes, some type of diabetes, is the GAD, G-A-D. It's a very common blood test. And if it's positive, you most likely have type 1. If it's negative, you most likely do not, but it's not a perfect test. Sometimes we have to measure it twice. Sometimes we measure other autoantibodies as well. And the other thing I want to say is that your doctor, if they think you're type 2, they might put you on metformin. They might put you on an SGLT2 or even Ozempic, and you might respond to some degree, and that even fools them more. But what happens is you don't respond well enough or typical enough, or you don't respond over time. And that's where it gets really frustrating. And then your caregiver sometimes says, hey, you're not being adherent. You're not really taking the medication, And so it could, if you could read about it in the New York Times, people have written articles about their misdiagnosis there.
Now, sometimes people, it's worth, mentioning now that sometimes people will say, my doctor told me, sometimes my doctor will tell me that I have, double diabetes. What does that mean? I have type 1 diabetes, but they said I have features of type 2 diabetes. Can that occur? And yes, it absolutely can occur. So when that most recently, what that looks like is that you have type 1 diabetes, like I got it when I was 15, but maybe you have a family history of type 2. Maybe you would have gotten type 2 diabetes later in life if you didn't get type 1. And you can start developing insulin resistance, have issues with weight like anybody can.
Yep.
And in those cases, you might be a type 1 that actually could legitimately benefit from some of these other medicines like Ozempic or metformin, things like that. So there can be overlap between these conditions.
Yeah, they're not mutually exclusive. My most classic patient is a guy who developed type 1 when he was like 6. He was skinny mini, ketoacidosis, was on an insulin pump, and then we got to his late 30s and 40s. He started getting heavy in the abdominal area, which is typical for type 2s. Hypertension, abnormal cholesterol levels, everything with a type 2. And I used to write in my notes type 1 and type 2, and that helped get some of the drugs like the GLP-1s and SGLT2s.
Yeah, and not to belabor that, but most type 1s will develop some kind of insulin resistance. So if you want some of these other medications, it's worth talking to your provider about, is there ways that we can, like there's a diagnosis code for diagnosis type 1.5, treated as type 2, et cetera. There's ways to not lie about the diagnosis, but make it more accurate to what you actually have so you can get, some of these other medications.
Yep.
So we've kind of hinted at type 2, Steve, but let's officially talk about what type 2 is and how it might be different.
Yeah, thanks, Jeremy. Well, type 2 is the most common type of diabetes in the world. It usually runs in families, as I said earlier, from generation to generation. And, although we have good therapies, we have no clue what causes it. It's basically a disease, what we call a heterogeneous disease of glucose metabolism. And what does that mean? It means there's a lot of different causes, but we do have good therapies. Typically, it's caused by insulin resistance, overproduction of glucose by the liver, and a reduced amount of insulin production by your pancreas over time that doesn't keep up with the glucose levels in your blood. So it's insufficient amount of insulin. Type 1s, we don't have any insulin. And it's also associated with a condition called metabolic syndrome. And that basically is people have abnormal cholesterols, abnormal blood pressures, the increased ability of your blood to clot, which is not good, heart attacks and strokes. We talk about inflammation. It's a group of cardiovascular metabolic abnormalities that lead to, unfortunately, a high degree of heart disease and strokes, but those are all treatable. So it's kind of a cluster of metabolic conditions, including high glucose levels. And I know part of Jeremy's research is some of those things we see in type 1, but we don't want to get off Jeremy going to type 1. We'll have any time to finish the program. But I know you got stuff to add to that.
Yeah, and it's also, as you mentioned before, highly genetic. It runs very rampantly through families. And to be specific, if you have type 2 diabetes and you have an identical twin, there's a 100% chance that that identical twin will have type 2 diabetes. And in type 1, that's only about 50%. And I like to highlight that because a lot of times people will say, Oh, type 1 diabetes, you got it, as a kid, so that's the genetic one, right? Well, there's a genetic component, but actually type 2 is much more a result of, good old mom and dad. They gave you some genes. Doesn't mean you're doomed, but definitely, it runs in families.
Yeah, even if one first-degree relative has type 2, your chance is up 30%. And then it runs very high in certain ethnic groups. African Americans, Pacific Islanders, Native American Indians, Latinos, and Asian Indians. Why is that? Well, it's in the genes. Not Jordache, but their genetic makeup.
Jordache, it's a good reference. And
That's an old
again,
joke,
to contrast, type 1 is mostly Caucasians. However, it's increasing rapidly in these other ethnic groups, more so in Caucasians. So these other groups are kind of catching up, if you will, Black, Hispanic, etc. So again, you can see that the blurred lines of classic type 1 versus type 2 as it's all kind of coming together.
Yeah, and just real quickly, we're not going to talk about the therapies in general, but through the years, as they discover another abnormality in people with type 2, they come up with another pharmaceutical agent. So we have the older sulfonylureas that stimulate the pancreas to secrete insulin, and the pancreas can be responsive. Then they came up with metformin, which blocks the liver from producing too much glucose. And then, of course, I'll skip the DPP-4s and I'll go right to the SGLT2 inhibitors. And those drugs work by making people pee out excess glucose in their urine, because we know that people with type 2 hang on to it too longer. And then the GLP-1 receptor agonists, Ozempic, Trulicity, Mounjaro, these are drugs that actually replace a natural hormone that's deficient in people with type 2. And we know what those drugs do. They get out the laundry list of things that they help in, including weight, glucose, cardiovascular disease, etc. So we do have a lot of good therapies, and it takes a good healthcare professional to pick the one that's going to work the best in you at this particular time in your life. So that's type 2.
Yeah, and if you're listening and you say, I have type 1, why do they get all these drugs?
I told you, we go right back to type 1.
And this is why it's important to know that the different, what we call pathophysiology of, then in type 2s, we're treating mostly insulin resistance and excessive weight gain, obesity, etc. In type 1, it's all about insulin deficiency. We don't have enough insulin. And while some of these meds can help with both, that's why there is such a discrepancy in terms of the different medications that we use.
Yeah, and we're coming together on every aspect. The technology, the glucose monitoring, the medications, and there will be a time someday where they won't differentiate as much.
Beautiful future
You
world.
can stop crying.
All right, so we talked about type 1 and how there was a pre-type 1. Well, guess what? If you type 2 diabetes, there's a pre-diabetes. And what does that mean? Well, that's a period of time where essentially your blood sugars are mildly abnormal, but not enough to put you in like the type 2 category. And the important thing about the pre-diabetes category is that we just know as soon as your blood sugars creep up a little bit, that puts you at a much higher risk of developing type 2 diabetes. So the good news there is that it's a time that you can potentially intervene, tighten up, with exercise, like diet, maybe try some of these other medications. The most effective way to prevent yourself from going from prediabetes to type 2 is actually with weight loss.
Yeah, that's probably the key. Now, when Jeremy was in high school, this is not a joke, I was involved in a government study called the DPP, Diabetes Prevention Program. It was a huge study, 25 centers around the United States, and we took people with prediabetes. And how do you diagnose prediabetes? It's all based on the blood sugar. Your numbers aren't in the normal range, and they're not in the diabetic range. So I'll just give you the A1C. A normal A1C is definitely less than 5.7. Prediabetes is 5.7 to 6.4, and diabetes is 6.5 and above. The same classification for type 1 and type 2. And in the prediabetes stage, there's typically no symptoms. So as Jeremy mentioned, you just go along minding your own business. Now, the way I look at prediabetes is sort of like LADA, except on the other end of the spectrum. It's type 2 diabetes, getting it earlier. And the pathophysiology is exactly the same. All these abnormalities I mentioned, they come on slowly. And your blood pressure probably is becoming elevated, your cholesterol, your glucose levels may be becoming a little bit abnormal. And there's nothing better than to make that diagnosis early. And guess what? There's a whole area of how do you treat people. Oh, lifestyle. Now remember, if you have prediabetes, it probably runs in your family. You're going to be at risk for getting heavy, especially abdominal obesity, as we say. And it's tougher to lose weight when you have type 2 or prediabetes. And there have been so many studies looking at the drugs we use once you're diagnosed with type 2, but use them early. Like you take drugs like Mounjaro, Ozempic. They've given them to people with prediabetes. In the last publication with Mounjaro, which is the new drug by Lilly, it reduced the people with prediabetes 94%, put them into the non-diabetic range. Now, if you stop the drug, they probably won't stay there, but that's true with anything. And nothing better than to start early.
Yeah, I was just going to say, whether you have type 2 diabetes or prediabetes, being aggressive early rather than waiting for, oh, my A1C to be above 8, and then I'm going to get serious. We know that the more like you can attack this earlier, it can just, set up your life in a positive way. But we also really understand how this term pre-diabetes can be confusing. We have a video of me the other day where I was diagnosed with a very serious condition and wanted to show it to you guys.
How's it going?
Hey man, what's up?
Hey, what's with the pre-Jeremy sign?
The what?
The pre-Jeremy sign, right there.
What? How long's that been there? What does that even mean?
Well, listen, I'm a little bit of an expert in this area.
Okay.
Turns out it's a condition that increases your risk of becoming Jeremy.
Increases my risk? Well, what am I now? And when will I become Jeremy?
Well, you may never become Jeremy, but then again, you might.
Well, gosh, are there things that I can do that will increase the likelihood that I'll actually become Jeremy?
Of course, and we're going to talk about those.
Steve, is pre-Jeremy going to be okay?
Of course, he'll be okay, as long as we get you educated, and we're going to do that right now.
All right. I feel a lot better already. Thanks, bud.
Alrighty.
Well, I'm happy to say that just like 4 or 5 days ago, I became Jeremy. So I was successful. But in this case, you want to avoid becoming, diabetic, et cetera. So there's some few things you wanted to kind of round out with prediabetes. Right?
Yeah, just a quick sentence. If you're watching this live and you want to know if you're at risk for type 2, well, as Jeremy mentioned, family history is key. Do you have weight problems? And it's not just regular old weight problems. It's especially around the abdominal area. If you have your cholesterol levels are abnormal, specifically, doctor tells you your triglyceride levels are too high. If you have high blood pressure, and if there's a lot of heart disease in your family, you might be at risk, and it's so easy to get tested. That's it. You just want to get diagnosed early. It's just pre-type 2.
Now, the last thing I'll say on this topic, I know I keep saying that, is that while I said that, type 1s can develop, aspects of type 2, does it work the other way around? And the most common thing I hear about this is somebody that's had type 2 for a long time and they have to go on insulin and they'll say, well, I became a type 1. And that's not the case. That most type 2s over time will eventually require some insulin therapy. And it's not that you became type 1, it's just that as those insulin producing cells start to fail over time, you might require insulin. So you have some features, if you will, maybe of type 1 diabetes, but we don't say you acquired type 1.
Yeah, you are officially a insulin requiring type 2 person with diabetes. And at this point, you're going to start, you might even get into an insulin pump that's designed for people with type 2. So it's, unfortunately, most healthcare professionals know about this, but sometimes it's missed, and it's important for you to straighten them out if they tell you, you're now a type 1.
Yeah.
So you just, no, you don't do that.
Well, let's talk quickly about gestational, and then we'll end with MODY.
Okay,
maybe.
sounds good.
So gestational, we're not going to spend a ton of time on because we just did an entire podcast with Dr. Thomas Moore, who's been in the gestational diabetes biz for 30 years at least. And I think we did a live with him also, or at least a
They
dose.
did some reels and things.
Yeah, we did. So a lot of good information there. So obviously a huge category we could spend a lot of time on. Some key things is that obviously gestational diabetes, developing high blood sugars during pregnancy, it tends to go away when you deliver the baby, but it's just a real marker for increased risk of you, the mother, becoming diabetic later in life. So it's essentially like having prediabetes. It's this wake-up call that you might need to be more aggressive with all these things we've already mentioned, weight, potential medications, etc.
Yeah, and it's extremely important to get under really good control while you're
Yes.
carrying the baby. In reality, if you knew ahead of time, you would have good control at the point of conception.
Yeah.
That prevents perinatal, genetic, physical abnormalities. But if you have good control during the 9 months, it'll help you deliver a healthy baby.
And while we're on the topic, the main risk is that if you have high blood sugars during pregnancy, it can just result in a large baby. That essentially the baby is releasing insulin to control the blood sugars, and insulin makes the baby grow. And if they get too big, it can make a complicated delivery. It might need more, C-sections, these kinds of things.
Yeah.
So it's important to control your blood sugars during the pregnancy, and then be aware after you deliver, even though it might go away, that it's potentially a sign of type 2 later in life.
Yeah, and extremely important. And typically, if you go to a big university like UCSD, we have a high-risk OB clinic, and they take over and they manage everything. And then patient comes back, hopefully with a healthy baby at the end of a successful pregnancy.
And because Steve always says, I bring up type 1,
Ah.
it's not uncommon for people to become pregnant and that to be kind of a final stressor that might bring out type 1 that they were kind of teetering on the edge of. So that might happen also, that you might think, I got pregnant and it gave me type 1 diabetes. No, it was just that you're already on your way there, and now you have some more like metabolic stress, we would call it, that brings it out.
Yeah.
Sorry.
No,
So you want to talk about MODY?
Yeah, now MODY is important to mention and not talk about too long. MODY stands for Mature Onset Diabetes of the Young. So think about that. It's not type 2 diabetes in the young, because run-of-the-mill type 2 diabetes does occur in kids. It's occurring in young children more and more. This is a specific genetic abnormality. Now, believe it or not, there's 13 different types. And in these different types of MODY, I'm not going to get too heavy duty on you, there's usually one specific defect we can point to. And that's why we call it a monogenic type of diabetes. I told you earlier, type 2 is a combination of many genetic abnormalities. And so it's different. It usually occurs if you're less than 25 years of age. It's usually missed completely. Some people diagnose type 1, some people diagnose type 2. Some of the different MODYs respond great to the oral medication, and some of them don't respond to those medications at all. They respond better to insulin. So there is a lab that you could send your blood to, your doctor, and they could do an analysis and tell you which type of MODY you have, which will tell your healthcare professional what's the best form of therapy.
Yeah.
So it's basically, I would just say to you, if you have a form of diabetes, they don't know what the hell you have. It could be MODY.
Well, when would you tell somebody, like what's the classic MODY patient? When should somebody suspect maybe I have this?
Well, they get, let's say they're diagnosed with type 2 at kind of a young age, and they don't respond to any of the medications that the doctor is giving them, at least the orals. And they might have the type of MODY, a very common one, that you require insulin. Or it runs pretty strongly in families, and everyone had kind of a hard time getting the specific diagnosis. So yeah, I would just say, if things don't make sense to you and you've been diagnosed with type 2, let's just say type 2 for now, and you're not responding normally to medications, you should think about MODY, and especially if you got it when you're less than 25, because that's what the OY is of the young.
Right. And, if it's type 1, they can check these antibodies and a C-peptide. That would help kind of clarify that way.
Yep.
Or they can do this genetic analysis for these specific defects that would give you MODY. And MODY, by the way, is generally very much easier to control. There's some versions that people don't even require therapy and have no issues with. but it's just something to be aware of as one of these kind of esoteric, strange forms of diabetes that we don't talk about that much.
Yeah, and we wanted to be complete today, and I think we definitely covered the major forms and types of diabetes. And so now you know there's not just type 1 or type 2 or gestational.
Oh, I see our notes here that we forgot about type 3 diabetes.
Oh, yeah.
Which is running rampant, really. Like there's an epidemic of type 3 in the world. And what is type 3 diabetes, Steve?
Well, type 3, as TCOYD defines it, is a significant other, a loved one that does not have diabetes, but knows what it's like and is the person that helps you deal with your diabetes.
So everybody else here at TCOYD is a type 3, essentially.
Yeah.
And then we're type 1s. Can I also be a type 3 for you? I have double diabetes.
Yeah, you got double diabetes. Well, here's the thing. A type 3's, Dr. Polonsky, Bill Polonsky, our good touchy-feely friend at TCOYD, he would call some of you the diabetes police. You care, but you're a little bit too aggressive in your suggestions and watching over your loved ones. And then at the last conference, someone came up to me and said, I know what a type 4 is. It's a type 3 who got divorced.
Well, make sure to get tested for type 4 diabetes. All right, so now we have some questions.
Yeah.
We get into that you guys have typed into whatever platform you're watching in. And, we'll try to get to as many of these as we can. So it says, I'll just read these. I haven't seen them. Is it possible for type 2 to get in their mid-20s and not have high triglycerides or blood pressure at diagnosis? Is it normal for lifestyle and diabetes meds? Not enough, so insulin is still needed. So this is one of these classic things that if you're diagnosed in your 20s, that's already abnormal for type 2 diabetes. You should be at least considering type 1. And if you're not responding to medications and needing insulin, this to me is screaming you should at least check these antibodies, check something called a C-peptide, and just bring up the idea to your practitioner, hey, is there other forms of diabetes that we should be considering?
Yeah, and this could be MODY.
Could be MODY.
As well. So, when you said, yeah, you can definitely get it when you're less than 22, but usually, in my experience, when you get it when you're younger, true type 2, you're heavy.
Yeah.
That's like the basic,
Yeah.
physical characteristic. And these young kids that get type 2, Latinos, African Americans, these ethnic groups that are hit hard by type 2, but also Caucasians, they have one commonality. They have weight problems. So you don't sound like a type 2.
Right.
And we need your address because we're going to send you the bill.
All right. Any studies in TZIELD in LADA patients while we still have some beta cells? Assume since still have C-peptides. So yes, in general, so right now TZIELD is approved to delay the onset of type 1 in people that are at risk for developing it. They've actually studied it in new onset type 1, people that have just come down with high blood sugars. Doesn't matter if you have LADA or kind of a routine type 1, and it actually has been shown to help preserve insulin production. So it's likely, or they're moving forward to trying to get this approved to use in people that have just been diagnosed. And that's not there yet, but we're hopeful that we'll still have it to delay type 1, that'll always be there, but then potentially anybody that's newly diagnosed with type 1, this could be an option to help not completely resurrect or restore, insulin forever, but help, preserve function.
Yeah, so if you think about it, in this study that was done called the PROTECT study, people had to have type 1 within a couple months. And if they had it, if diagnosis was further away than that, they were not candidates. But if you think about it, if you're a LADA patient and your body secretes insulin, you might be in the same shape as someone newly diagnosed. So it's a good thought. And they probably will do some sub-analyses of future studies of people with LADA. And I think it comes down to if your pancreas is still secreting insulin, and it's getting slower beta cell destruction because you're a LADA patient, might be a good option.
Yeah. All right. Isn't propensity to develop autoimmune diseases genetic? Yes. These things run in families. They cluster together. So if I have a patient with type 1, I'll say, does anybody else in your family have type 1? They might say yes, they might say no, but it's very common for them to say, no, but my aunt had rheumatoid arthritis, or my uncle had celiac, or these other autoimmune conditions. They tend to kind of run together.
Yeah, you know the percent, if your mother has type 1 versus your father, you go through that. But before you do that, if we talked about the relationship in type 2, much stronger. But I know, if the father, someone's chances, what,
Yeah,
6,
but I think
7%?
like we're talking about just genetics in general, that the risk of our kids having type 1 diabetes is about, 6% or so. The risk of a non-diabetic having, a kid with type 1 is about 0.5 or 0.6%. So it's about a tenfold increase because, of the genetics. So it's not like 100% like type 2, but it's still got a genetic component for sure.
What I find is interesting, Jeremy, if, we're the dads of our 4 kids, 2 kids each, but if our wives were the type 1, their chances would be half as much. So, and you remember my old joke of why the chances are higher with the father having type 1?
Of course they do.
What is it?
I'm just not going to say it. We're going to move on. This is a family show. All right, so can long-term type 1 benefit from meds to prevent type 1? Probably not. So long-termers like us, we don't have any insulin-producing cells to save, period. So these medicines like TZIELD right now are designed to slow the destruction of existing cells. Honestly, what we need is some kind of islet cell replacement, some kind of therapy like that, which they're also working on in research, but these medications really wouldn't be efficacious.
I should mention, we've talked many times about a company called Vertex, and they have several approaches to replacing these viable beta cells that they synthesize. You don't have to go to, cadavers anymore or, abortion leftovers. That didn't sound very good. But they can synthesize active and producing beta cells and put them in your liver, where you may have to take a low-dose immunosuppressant, or put them in little capsules, and they put them in your body that protects them from the autoantibodies. It's important to note that you're always going to have these circulating antibodies pointed towards the beta cell. So people who have pancreas transplants, brand new pancreas from a donor, they still have to take immunosuppressants. And so it depends on the method. And I predict that by the end of this century or this decade, we're going to have a form of therapy where you can get islet cells. And Jeremy and I will be at the front of the line. You could be third.
All right, it's just a comment more. It took me a year to get a C-peptide test because my doc was convinced I was type 2. I was 61 and overweight. So good for you for advocating for yourself. Something doesn't feel right. These blood tests, by the way, C-peptide, these autoantibodies, are widely available, and not excessively expensive or esoteric that your doctor wouldn't know about them, so you can ask about them. All right, what do you know about COVID causing LADA? I ended up in the ER and was misdiagnosed as type 2 a year after COVID started. I had been managing it successfully with metformin and a strict low, no-carb diet. So there is evidence that in people with that get COVID, that they're at higher risk for developing type 2 and type 1. It's a slight increased risk. Now, what I would say to this is that it's likely in either case, type 2 or type 1, that you were kind of already on your way there. That generally we think of COVID as kind of another stressor to kind of like push you over the edge. I always tell the classic example, I'll say really quick, that when I came down with type 1, I got the flu like a week before I went into DKA. And I always thought that flu gave me type 1 diabetes. It wasn't the case. I had had these antibodies for years, was losing beta cells, didn't know about it, and that flu was the last thing that stressed my body and pushed me over the edge.
I thought it was going to Chili's, eating that rack
that
of ribs with the barbecue
that didn't
sauce.
help. little apple compote, super good.
Yeah, I think you're right. It's interesting. We always talk about stress, medical stress, bringing out type 2. And I'm a believer that that's why we're seeing a large increase in type 1s, because these stressors can also stimulate the immune system if your immune system is ready to be activated.
Yeah. This is a very specific question. I have type 2 diabetes, and currently I'm metformin, Jardiance, glipizide, my A1C's 8. What do I need to do? Please talk to your doctor, your provider, about other medications, because there's other good options, GLP-1s, etc. to get your A1C down, your weight, etc.
I'm going to send you a bill too.
Yeah, can you speak to GLP-1 use in LADA? So again,
Yeah.
I'm a big fan of GLP-1s like Ozempic, Trulicity, Mounjaro, in anybody newly diagnosed with type 1 diabetes, because there's some evidence that these can help preserve insulin-producing cells. And because of the ways they work, they can help lower blood sugars also. So you might be able to use one of these medications and not need to bolus, for example, etc. They can be very difficult to get covered because none of these medicines are approved for type 1 diabetes. So your doctor can prescribe it all day until they're blue in the face, but if your insurance company doesn't cover it, it's not going to get approved, and then they're just astronomically expensive.
Well, this is where the misdiagnosis of type 2 can help you, because if you're a type 2, then you are eligible to get these drugs.
All right, I think this is our last one. Islet cell transplants are limited to those with severe hypos because of the necessity for immunosuppressants. What about for those of us that are already on immunosuppressants for other autoimmune conditions, psoriatic arthritis, etc.? Could we get these? So it's a really good question. In general, the immunosuppressive drugs that we use for these other autoimmune conditions aren't as intense as what you would need for the islet cell transplants. What I thought you were going to say is that often, like if somebody needs a kidney transplant, for example, and needs some of the same kind of immunosuppressions, then absolutely we can give them a full pancreas or islets, etc. But it's not just kind of common that if you're on these other drugs that you would just get an islet transplant. Now, the other important point is you say you have to have a severe hypos right now to get these transplants. And we're trying to get rid of that criteria because people always say, like in the clinical trials, you need 2 severe hypoglycemic episodes in the last 6 months to qualify. Well, guess what? You and I could have 2 severe hypos today if we wanted to. So why make a ridiculous requirement that, I need to have a seizure or something to be in a study? Let us make the decision based on the risks and benefits.
Yeah, you have to remember that these islets are not approved yet. So you're talking about the clinical trial, to get into the clinical trial. When the clinical trial is over, and if and when they're approved, your doctor can prescribe it for you, no matter what. And I define a severe hypoglycemic reaction is when you have to get the assistance of others. Eric, get me that chocolate chip cookie. There.
Or the
Severe
assistance of
hypoglycemia.
I get notified that you're low and I text you, get it together.
Yeah. So once it's approved, you talk to your doctor, you look at the risk-benefit ratio of taking immunosuppressants, and if he feels it's going to help you and you guys agree, he can prescribe it for you. And, if you're taking it for other reasons, it just makes it that much easier. So a physician prescribing it for you is different than being an active participant in a research trial with strict entrance criteria.
All right. Well, that's going to wrap it up for us, and I think we covered a lot. And again, if you're saying, well, I only have type 1, why don't I hear about type 2? Knowing the different mechanisms, how these work, why a certain drug might work for you or not. If I'm thinking about preventing a disease versus treating it when I already have it, pregnancy versus not, all these things are relevant, I think, to everybody. And as you always say, Steve, we're all blood brothers. These things all are these different roads to kind of high blood sugars. And so we have to, the common, issue that we're trying to resolve, but how we get there might be a little different.
Thanks, brother.
Yeah, thanks, buddy.
Now get me the chocolate chip cookie.
All right, hope to see you guys throughout October for all of our fun stuff. See you at our November 2nd conference. Check out our podcast, which we just recorded another one.
Follow us, like us.
Do all that stuff. Send donations.